I think we're ready to start. Thank you guys for coming. So I want to introduce you to the second phase of the VA simulation immersion experience that we've got going on. So the first phase was the didactic that we had on Friday, okay? And learning theory is the more that you can integrate how the learners see or do or touch or feel, the more likely the learners are, that's you guys and actually us too, right? To remember the experience, to get something from the experience, to grow from the experience, and to understand the experience. So this second phase is going to be the most exciting phase. It is a live case presented to you. I'd like to especially thank our ICU attending today and our ICU fellow, that'd be Dr. Lambert and Dr. Vida, for joining us. I'd also like to thank the special guests in the back for coming and observing this as well. And lastly, I want to just say that here at the VA, we're trying to make sure that you guys have a full experience. This is brought to you guys by the inpatient hospitalist group, the VA itself, as well as the Department of Education here, okay? So it's kind of a nice collaboration that we've got going on among the three groups. So I hope that you guys enjoy it. And it looks as though, if I'm not mistaken, we have a sick patient that just called up. Does that sound right to you guys?
This is Mr. Jones. He's a 75-year-old male. He just came up from the emergency department. He has a 1-week history of progressive dyspnea and fatigue. In the ED, they gave him 2 liters of fluids and started him on vancomycin and cefepime.
Okay. So it sounds like they initially thought he was infected. Do we know anything else about this guy?
He has a history of heavy alcohol use, but other than that, we don't know any additional information. Looks like kind of in the past few minutes that we've been talking, he's been getting progressively more tachycardic, hypoxic, and showing a little more ectopy.
Okay.
I think it might be a good idea to do a bedside ultrasound to maybe see if we can figure out some more information.
Sure. Yeah. What do you think might be going on though before we start looking at what's going on in his heart? What do we think we might see?
Sure. We good.
Yeah. So this experience is an interactive experience. So when a question gets asked to one of the learners here, when the question gets asked to Dr. Lambert, it actually is heading to the audience. So I believe we have our first question.
So what we want to do here is a quick shock assessment. What would we be looking for on his heart? What do we think might be going on? Betsy, if I call this guy up to you, I say he's hypotensive, I gave him 2 liters in the ED antibiotics, and he's worse. What are the 3 or 4 things you want to find out? What are the 3 or 4 things you're thinking of?
What's the volume status?
Right off the bat. Yeah, volume status.
Okay.
Great.
Does he have a PE?
Yeah.
Sure.
Is this a pulmonary embolism?
Is he warm or cold?
Warm or cold? That's great. What's the difference there? What would make you think one thing versus?
Going at sepsis versus cardiogenic shock.
What would be cold? What would be warm? I guess.
Cold thinking more congestive heart failure and cardiogenic shock. Warm being septic shock.
Yeah, I think that's a great way for to kind of do your initial differential. Sure. Yeah. Okay. What other things could cause hypotension so suddenly? He's got a very heavy alcohol history. He came in not feeling well. Suddenly he's more hypotensive.
Bleed?
Did this guy just open up and dump a couple liters into his belly? Absolutely. So that's one of the other things. That would be more on
Does
the.
he have a bleed?
Yeah, a bleed. So that would be more your cold shock as well, right? As he's clamped down, hypotensive because there's 3 liters of blood in his stomach. Okay. Is this guy's sepsis just worsening? Sure. Yeah, he could be getting worse.
No one
Do you
mentioned.
want labs?
Yeah, let's see.
Yes.
Let's see what the labs they got down the ED were.
Okay, very good.
All right, I'll read them out. So he has on renal panel, he has a sodium of 130, potassium of 4.5, chloride of 108, bicarb of 17, a BUN of 79, creatinine of 2.4, glucose of 109. On CBC, he has a white count of 11.9, HNate of 9.8 and 31.0 respectively, platelets of 107. On hepatic panel, he has a total bili of 1.8 with indirect of 0.2, ALT and AST are 84 and 85, alk phos of 209, albumin of 3, calcium of 7.5, INR is 1.5, MAG is 2.0, phosphate is 3.4, he has a mild troponin leak at 0.09, NT pro is elevated at 46,000, lactate at 3.7, ABG 7.28, 32, 52, and 16. Blood cultures are pinned in.
What do you guys think about those labs? Are those normal or abnormal? Abnormal. What's abnormal to you?
The NT pro BNP is
Yeah, strikingly elevated. Yeah, and what about
He's got a nag to this one.
yeah, so he's got some evidence of acidosis as well. Probably mixed, not just NAGMA, because he's got an elevated lactate as well. But he also has evidence of renal failure, right? He's got a BUN of 80, creatinine at 2.4. Do you think this guy might be dry based on that? Probably not, because the first thing you said is that he had a very high high BNP. So one of the things you'd want to know is what's this guy's volume status? Is this guy dry based on the high BUN, or is this something else going on based on the high NT Pro? Anything else stand out to you on that?
Transaminitis.
Yeah, a little bit of a transaminitis as well. And then the lactate being elevated would also be a concerning thing to me. That's another evidence of, the way I would look at this is he's got evidence of end organ dysfunction on multiple pathways. You got some cardiac enzymes that are up, you have a lactate that's elevated, and you have a abnormal renal function with abnormal liver function as well. This person would be sick, they have multi-organ system dysfunction. So this guy needs your pretty quick attention, so I think we probably need to move on to do a bedside echo to see what else might be going on.
So first we'll start with the parasternal long axis, so with the notch toward the right shoulder. Toward the right shoulder. Between the third and fourth intercostal space, second or fifth if need be. Should be able to get an okay view here. I don't know if you can see around me.
So what are we looking at here?
Left ventricle.
Good. And this?
Mitral valve.
Good.
Alveolar tract.
Good.
Right ventricle.
Okay, do you remember what we talked about on Friday? The 3 things that you look for in order to determine a normal versus an abnormal EF. Does anyone remember the 3? What were they?
Wall expanding greater than 40%.
Okay.
Foot touching essentially the outflow tract wall, and then symmetrical movement of the walls.
So say those again, and let's see as we look at this view what the 3. So the first one was what?
We'll go with symmetrical movement.
Symmetrical
Walls.
movement. So this septal wall and this outside wall, are they moving symmetrically inward?
Not really.
Okay, so not really. What's the second thing you say?
So the anterior leaflet kind of flipping all the way up to the opposite wall.
Okay, good. Does it look like it's getting within, do you remember the number? Within 1 centimeter of the septum?
Sure.
Okay, good. And does it look like yes or no?
Doesn't really. It's a little grainy. I can't really tell, to be honest.
Is this
All
guy
right,
right here?
so-
No, it's
there it
not.
is.
No.
Okay, and the last thing that you said was?
Does the wall expand greater than 40%?
Good. Does the myocardium thicken by 40% or more? And you can look at the septum here, and does it appear to?
No.
Okay, so we have a hunch of what's going on, but remember you can't call anything by just one view.
So next view, do the parasternal short axis view, so rotating the probe 90 degrees with a notch toward the opposite shoulder.
I think that's perfect.
That's good.
Yeah. Okay, can I get someone else to interpret this?
So you're right, it's your parasternal short axis. What's the, can you point out some of the anatomy that we're looking at right now? Because that's the first thing first. You have to know if you trust your window or are you actually looking at what you want to be looking at. So right there, I'm seeing the left ventricle where it's currently being outlined. Seeing a little bit of the valve there, it looks like. To me, it looks like it's kind of a diffusely decreased cardiac function there.
Okay. Good.
But
So
then
now-
enlarged are.
Apical?
Yeah. So next view would be the 4-chamber apical, so with a notch toward his posterior left axilla, and just below the inferolateral nipple.
Okay. Good. Can we get someone to interpret this one?
So on the top right of the image is the left ventricle there, and then beneath that is the left atrium. And then top left of this image is the right ventricle, beneath that is the right atrium. Valves look to be okay. It looks to be kind of just not squeezing very well. Probably.
Good.
Especially the right seems to be rather large too, for this image at least.
Yeah.
I-
Do you see any fluid collecting around the heart? Anything in the pericardial sac? Any fluid?
I don't.
No evidence of infusion. I agree.
So next view, we want to do the subcostal view. So with the notch toward the patient's left, just below the xiphoid process.
So I think it's a pretty good window there. What do you see? So we're in the subxiphoid. We're looking at 4 chambers right now. If you're coming through, what's the first chamber you would encounter if you're coming across the heart like this? Are we going to see the left side first, or are we going to see the right side first? What's the first cavity you're going to come across? Yeah, the right side, right? So what's the arrow at right now? That is the right ventricle. And what goes into the right ventricle? The right atria. The IVC goes into the right atria, right? And if we first encounter the right side of the heart as we're cutting across it with our ultrasound beam, what's the other side going to be? Yeah. All right. So left ventricle there. Left atria on the other side. One thing that stands out to me is just the right ventricle is as big, if not bigger, than the left side. So that would be evidence of right side volume overload anyway. And then the left side to me doesn't look like it's squeezing great. Again, I don't see any evidence of a pleural effusion or pericardial effusion. And then both atria seem to be a little bit enlarged.
And this using what as a window? What is this as a window here? Good.
Yes. So last view we'd want to check would be taking a look at the IVC. So with the notch toward the top of the patient, toward the patient's head. Okay. So we can see the IVC, solid hepatic vein going into it. We see very little variation with respiration. Do we want to measure it?
Sure.
So measures that are like 3.5 centimeters. So it appears fairly dilated with minimal respiratory variation.
Okay. So if you were to sum up this guy's 5 views of his heart and as part of your shock assessment, what would you describe him as?
So overall, we see decreased cardiac function, no evidence of pericardial effusion, does appear to be volume overloaded or have a high volume status. So it looks like he's been adequately resuscitated from a volume standpoint, but has fairly poor contractility or squeeze.
Yeah, that's what it looks like to me. So while we thought this guy was infected coming in, it looks like his current presentation with the hypotension, the tachycardia, and the hypoxia might be related to more cardiac dysfunction at this point. So what do you think we should do to kind of to get him back where he needs to be? What should we start for him?
Probably pressor support.
Yeah, I'd start him on some Levofed, see if we can get some better systemic perfusion, and then as we try to get some fluid off of him.
Levofed is infusing.
And I think kind of to interject here, I think this is a very useful tool right there, because I think that should be done in about 2 minutes, and we do it every patient who comes into our ICU hypotensive. You have 2 to 3 minutes to really assess what's going on with the LV, the RV, does he have a large effusion, and what does his IVC look like? So I think that's a really good example of what you would expect to see on a patient with heart failure. The LV is not contracting, the RV is mildly dilated, the IVC is dilated, and just contraction is poor. So I think that this would be the treatment for this gentleman. Okay, so 24 hours go by.
So looks like with pressor support and some diuresis, got a normalization in his heart rate, his hypoxia is resolved, and his blood pressure is much better. So I think it's worthwhile to note that in this gentleman who came in septic appearing and was initially treated for sepsis, bedside ultrasound was able to kind of guide our diagnosis toward a different cause of shock, in this case cardiogenic, and changed how we would manage that. And as we can tell so far, outcome appears to be improved.